Hello, it is Friday again, and I'm back after last Friday being on jury duty, actually. I'd much rather be here doing this, that's for sure, though I do believe in supporting my country and serving. I'm Julie, I'm the owner of Re+active Physical Therapy and Wellness. We're a neurologic PT fitness studio with 2 locations in the Los Angeles area. Also home to the Schmidt Movement Disorders Fellowship, which is right now the only neurologic-based fellowship program for PTs in the country. And one of the reasons that we dive into these weekly videos every week, and this one in particular came specifically a question from one of our fellows, as well as questions that people have emailed me or asked over the course of time about Parkinson's disease and specifically the Parkinsonisms. And how do we know? How can we quickly screen, especially using our movement analysis? So that's what we're going to talk about today. And we are going to do this highlighting a couple of things. We're going to talk first about some of those key distinctions in the Parkinsonism. So cortical basal degeneration, which is CBD, multiple systems atrophy, which is MSA, and then progressive supranuclear palsy, which is PSP. And we're going to talk about our advanced movement analysis skills to distinguish those. And you'll see me refer or hear me refer to this, or I'll bring it up as well. This is a little cheat sheet that we have created for movement disorder specifically to help distinguish some of these things. So I'll talk about this and we'll talk about the key distinctions using quick screens with movement analysis to help distinguish between those, as well as get baselines and check for progression. And then we're going to end with talking just briefly about the model that we use for intervention based on some of the work that we've done with Carolee Winstein and Dick Schmidt himself, who we named the Movement Disorder Fellowship excuse me. So let's dive right in. So what Chrissy, our fellow, had asked, and we've talked about this a few times with some of her patients, is how do I really know, is this Parkinson's or Parkinsonism? What are some quick things that I can look for? And by the way, this comes up at such a good time because actually our next week that we do teaching at USC. So I teach at USC, I teach neuropathology. We're actually talking about movement disorders and Parkinson's and Parkinsonism. So I've just been in a lot of this literature and in the material for this a lot in the last week. So it's nice when everything overlaps like that. So first we have to think about Parkinson's disease and what the hallmarks there that we see. So we see tremor, we see bradykinesia, slowing of the movement, rigidity, postural and gait disturbances. And the reason that the Parkinsonisms can be so confusing is that they usually have all of those things as well. And then it's distinguishing what pieces are a little bit different. So here's where I want to start with the worksheet. By the way, I'll post a link where you can download this. We've made it free and available for everybody. But this is the process that is very helpful for coming to that differential diagnosis. And by the way, there's also a great article. I'll post a link to that because it's free, full text as well. So on here, you can see there's 2 columns. One column that we're going to be in today is really for differential diagnosis, and then the other is more of our movement analysis biomechanically. But when we start our movement analysis for movement disorders for differential diagnosis, the first question we ask is there insufficient movement versus too much movement? So we can think of hypokinesia or hyperkinesia. And typically when we think of Parkinson's, we think of hypo, insufficient movement, akinesia, bradykinesia, all of those. On the other hand, though, we do see some things that are too much movement, and those are classified as jerky or non-jerky movements. Jerky movements include myoclonus, chorea, tics, not things we see a lot of in Parkinson's, but we may see myoclonus in some of the Parkinsonisms. So we'll talk about that. The non-jerky movements are tremor. We definitely see this in Parkinson's, and dystonia. And we can see this in Parkinson or the Parkinsonism. So we're going to talk about that. So insufficient or too much movement. If it's too much movement, is it jerky or non-jerky? And then the second question helps us a lot because we're going to characterize that movement, because just the presence of one of those things doesn't help us, but it's where it is and what the pattern is. So I want to start with the first part of this worksheet where it says key Parkinson's disease plus findings. So we use the term Parkinson's plus or Parkinsonism pretty interchangeably. So some of the key findings that we have, we want to screen the head, the face, and the eye position. So if we see, for example, retrocollis or really upright posture, maybe the head is back, that may be a sign of PSP. So typically in PSP, there's an impaired downward gaze. There's also a typical kind of surprised look on the face that can come with PSP. So screening that as well as our eye movements may give us some hints or clues about PSP. Second, we want to look for dystonia, especially in the limbs, or an alien hand, which is an interesting term, don't you think? But essentially what I love to think about is actually what my patients say is it feels like my hand's not attached to me, and they call it, and they're looking at it and it's hard to control and place in the right place, but it's not necessarily a coordination problem. That is really a what I think of like posterior parietal lobe, sensory integrative function in the hand is impaired. And this is something that you can see in cortical basal degeneration. So screening and looking for dystonia unilaterally, especially in the hand, and those alien hand movements. Third is the trunk position. So typically in Parkinson's disease, we'll see a forward trunk. In a lot of the Parkinsonisms, we'll see a very upright posture, maybe even backwards, maybe even falling backwards, and that's much more typical of PSP. And again, none of these things is like the home run for one of these disorders, right? So we start putting the pieces together to build a clinical picture. The base of support, this is one that early on in my career when I was working with a movement disorder neurologist, we were talking about a patient and he said, yeah, it's definitely not Parkinson's disease. He has a very wide base of support. And I was like, oh, well, I thought that's because he had spinal stenosis. Well, it might have been stenosis, but what the neurologist was teaching me is that the wide base of support is much more typical in a Parkinsonism, especially MSA, where there might be a cerebellar component, but not a clear ataxia. And it's a great little hint. Look for that base of support. Typically in Parkinson's disease, it's much more narrow. So we talked head, face, dystonia, trunk, the base of support. The next piece is looking at what their postural stability looks like, and especially that postural response being really impaired and having falls early on. That is definitely a flag for Parkinsonism. And then, is freezing of gait an early problem? And so this was a great question. Valerie Johnson had emailed me about this, as she's another really fabulous PT. There is a disorder called primary progressive freezing of gait. And it's something that I have seen. And typically when I've seen that, it ends up becoming a Parkinsonism or something else, something like Lewy body dementia. I've even seen where it was a hereditary spastic disorder, but this it was originally just presenting as freezing of gait, and may have been termed primary progressive freezing of gait, which is really interesting. Not typically the first symptom in Parkinson's disease, but it may be an early sign of one of the Parkinsonisms occurring. So that is shown a little bit in the literature as well. So something else to think about. So those are the big things that I look for. So head, face, eye position, dystonia or alien ham, the trunk position, the base of support, early falls, and this early freezing of gait. These are all things that I look for in a Parkinsonism. However, there's more. So I have to share, there's this handbook called Handbook of Atypical Parkinsonisms. It's fabulous. If you have access to an academic library, I really recommend it. I was reading through it. They have all these wonderful resources to compare some of the movements for the atypical disorders, like tremor. So in Parkinson's, typically we see a unilateral pill rolling tremor. And this actually does not tend to happen in the Parkinsonisms. In MSA, it might be more of a postural tremor. It may have myoclonus. In PSP, tremor is not very common, but in some of the phenotypes of PSP, it's there. And in cortical basal degeneration, CBD, it's a little more like a myoclonic jerk. So even just looking at the quality of the tremor, you may pick up some subtle signs. Also, looking at the rigidity and the pattern of that. In Parkinson's, it's almost always asymmetrical, and in MSA, you tend to get bilateral, and in cortical basal degeneration, it's usually quite severe and very asymmetrical. And in PSP, this is definitely my clinical experience, it's much more axial in the trunk. So even that pattern of rigidity can help distinguish between those Parkinsonisms. I find this so fascinating. And then, as I mentioned, in the posture, so typically in Parkinson's, we may see a flex posture or camptocormia in a small percentage of the cases. MSA is much more likely to have a Pisa syndrome, which is that shift in the posture. As I mentioned, PSP tends to have that really upright posture and the retrocollis in the neck. So again, we can look at the posture for clues. So the tremor, the posture, and the pattern of rigidity all give us clues to distinguish between these. So I want to put all those pieces together and just hit on the big three. So if we talk about PSP, you definitely see progressive Parkinsonian symptoms, but that comes with the vertical gaze palsy, that real axial rigidity, backwards movements with some facial dystonia. Those are some of the hallmark features of PSP. Versus MSA also has this Parkinsonism, but it may have a cerebellar presentation, may have upper motor neuron signs. We see the myoclonus. And then this one we don't necessarily see in our movement analysis, but the dysautonomia is very profound. So those are the cardinal features of MSA. And then finally, in cortical basal degeneration, we also see the Parkinsonism, but we see it accompanied typically by an upper extremity dystonia or alien hand, these cortical, meaning like posterior parietal type sensory deficits, apraxia, and the myoclonus may be a part of cortical basal degeneration. So that gives you a little example of how to kind of compare and contrast each of the Parkinsonisms and some really nice clues for when you're watching them move, how to distinguish this. So this is really helpful in the clinic, in talking to the neurologist, and talking to your patients as well. And then, briefly, just hitting on a little bit of intervention. So some of the questions and discussions that I've had is like, but the Parkinsonisms can be a lot harder to treat. They may progress more quickly. They may have more really profound deficits, especially in the dystonia realm or the rigidity realm. And so what can I do? And so I'm not going to give you a whole dissertation on treatment methodology in Parkinsonisms. That will have to be another time. But I wanted to share this. This is something that Carolee Winstein, and actually it was a group from USC who was working with Dick Schmidt. So this is Richard Schmidt, who many consider this father of modern motor control and learning. I certainly think that. He is the namesake of our fellowship program and was a client of ours who had cortical basal degeneration that actually progressed to include PSP. So we wrote up and presented a poster at CSM one year. Actually, Dick helped write it up, which was really cool. How often do you get to include a patient in your write-up? So what we developed and talked about was looking at, and I hope that you can read this here, looking at where we can help somebody improve their reserve capacity through physical therapy intervention, and especially when they may have a degenerative disease that is progressing rapidly, where we can come in and boost that reserve capacity through physical therapy intervention. In my experience, that intervention is much more intense than it is, much more frequent than it is with somebody with typical Parkinson's disease. And it involves a lot of members, PT, OT, family, personal trainers, to keep boosting that reserve capacity up and weighing the big pieces of safety and capacity. So having compensations where needed to stay safe, but still pushing and challenging. And I've definitely found that people can make gains and stay at a really good functional level for a longer time through that. We were able to show that in a case with Dick Schmidt. We presented those results where he actually made some really great improvements with upper extremity control, with balance, with his walking through a very frequent and intense physical therapy. So that is the good news, the hope, actually, when somebody has a Parkinsonism and it may be progressing more rapidly, that we can really intervene and help slow that down. So that's what keeps me going every day, and I hope you found that helpful as well. So I'm going to post a couple links to the articles, and again, this movement analysis cheat sheet, I'll post a link because you can grab that for yourself, and maybe that will be helpful for you in doing this differential diagnosis. Thanks so much for joining today. Next week, we will be at CSM. Chelsea Richardson here at Re+active, Carly Lockala, Mike Studer, and I are presenting on functional movement disorders. We've got a 2-hour course on that on Friday morning. We're going to come with a little Facebook Live afterwards to let you know some of those take-home messages. So join us next week for that. We'll be in Colorado, and have a great weekend.